Friends, welcome to another Transforming Chaplaincy webinar. We get to talk about palliative care and spiritual care. We've got two fantastic guests with us to be featured, and you can see here on the screen the first guest is that we want to introduce in a moment here is Dr. Betty Ferrell, who's been doing this work for decades, and we're calling this spiritual care research uh, and practice together. If you've not met me before, my name is Paul Galshoot. I get to serve as the Assistant Director for Engagement. I get to host these for us. So if you're all about spiritual care and palliative care, you're in the right place. If you're looking for explanations about drones on the northeast side of this country, I'm going to invite you to go elsewhere. But if you want to have this conversation with us, that's where we're headed here. Just want to give a quick plug for when we're not doing these webinars online. We try to get information out to you with the latest evidence or some education that's coming up, and we'd love to have you slide in. I try to change out this slide picture. In the summertime, it's usually more baseball-like. Had Jackie Robinson last week, or last week it was a curling, and then this week I'm going back here. This is me with my big sister and my dad in good old Minnesota years ago. This is a free community platform. We'd love to have you be a part of it. One of it is focused on serious illness or hospice and palliative spiritual care. In January, in the new year, this is our last webinar of this year. Bet Steller from Australia will be joining us. And it looks like that, I'm guessing, in Australia right now, but this is a quick way for you to get into that. It's on January 9th. As you can see, they're focused on meditation for older people and that mindfulness there. So an expert to be a part of that, and that's led by our Elder Care Research Network. And then with us are our two guests. First, let me introduce Dr. Betty Ferrell, and let me also add that these two bullet points does not do sufficient job introducing you, Betty, but for the brevity of getting into this conversation, uh, Dr. Betty Ferrell is the Director of Nursing Research and Education and is a professor at the City of Hope Medical Center in Duarte, California. Additionally, Betty is principal investigator of the End of Life Nursing Education Consortium, or as many of us call it, LNEC project. And that is, Betty, you'll have to tell us in how many languages at this point, but there's so much else. And I can think of ways that you and I are interfaced, Betty, but thanks for these important details about who you are. And then my friend and chaplain colleague, Danielle Gilchrist. Danielle serves as a palliative care chaplain in North Philly at the Temple University Hospital there. And she is also, along with me, we have to be PhD students together with the University of Maryland, Baltimore program. So, friends, we're having a conversation, and I'm going to take it away and drop these slides. So I'm going to go off screen. Thank you, Betty and Danielle, for having this conversation about this research and practice of spiritual care that we do together and caring for people with serious illness. Take it away.
So I just first want to say thank you so much. It really means a lot to me to be able to have this conversation with you, Dr. Ferrell, as I am more new in this field of research and spiritual care research and palliative care. And so be able to talk to you and understand your history, your breadth, where you see things are going and where they've been, and how we can collaborate more in order to progress and move the field means so much. And so I'm very excited to be here. And thank you, Paul, for this opportunity.
Thank you. And I just have to comment, it's always a joy to be with my chaplains colleagues anytime, anywhere. But I think it's an important thing to just point out that here we are on this call with two amazing chaplains, Danielle and Paul, both who are in PhD programs. And that, I think, is a true sign of progress for the field, that we know the wonderful work of chaplaincy, but to see more chaplains involved with research and really advancing our knowledge about spiritual care, it's a good day. So thanks to both of you and all the chaplains who are trying to move this field ahead.
Yeah. So I'm wondering if a good place to start in conversation is really just with a little bit of, I think maybe especially your history, Dr. Ferrell, and because if I am correct, you've been in nursing for just shy of 50 years.
Yep, 2027 will be my 50th year. I've got to plan a really big celebration. So this is 2024, so 47 years this year in nursing. I'm about to start my 48th year in nursing, and proud of every year and grateful for every single day. I always say I wake up every day of these 48 years and am very grateful to be a nurse.
Oh, wow. Well, thank you. Thank you. Much respect and a lot of honor, because that's a lifetime of work, and you've certainly made an impact on the field. And so with this 50 years or 47 years of experience, can you tell us a little bit about, I know that you start, I know that you kind of, I've heard you say cut your teeth in pain and symptom management. And so can you tell us a little bit about your introduction and how you got into spiritual care, and how that's kind of unfolded through your research and
Sure. I'll start with just my clinical beginnings, and then I'll sort of comment about um, how I moved into this as a researcher. But I started work as about 20-year-old in an oncology unit, and it was crazy. I mean, it was the Wild West of oncology. Oncology was just beginning. It was the first ever in my area, a dedicated unit for oncology. We were giving the first chemotherapy. It was really, really difficult times, and of course, extremely high mortality. And I worked on this 40-bed oncology unit, and at the time, one of the biggest challenges was everyone was diagnosed with very late stage disease. Everyone was in excruciating pain. And at the time, we had meperidine, Demerol for pain, IM injections. We still gave placebos. We had very little, and so as a result, that made every day, almost every patient was in excruciating pain. But I think, besides this horror of this lack of good ways to treat pain, as a young nurse and working the evening shift, so being there at night with these patients, I became acutely aware early on that there was more depth to this pain than physical pain. Or, I would later say I started encountering a lot of pain that no amount of morphine, would treat. And so really early on, I mean, probably in the first hours or days of being a nurse on oncology, I just became profoundly, profoundly aware that when people were diagnosed with cancer, or certainly at the end of life, and they were ringing that call bell saying, I'm in pain. I mean, I knew that when I went into that room that it was more than physical pain, that I was witnessing suffering.
okay.
That these dear, dear patients, my teachers were really, expressing to me issues of forgiveness and faith and their spiritual lives and regret and faith, that people who really relied on their faith to deal with their cancer and with their pain. And so it just was there. And of course, the more you were willing to pull up a chair and sit and talk to that patient, then you really learned about their pain. And that was my clinical introduction. And the one other thing I would say is, in this really crazy time of this 40-bed new oncology unit, myself and two other nurses for the whole shift, there was a social worker and a chaplain. And I think there was probably one chaplain for the whole hospital, one social worker maybe for oncology. But that chaplain and social worker became the calm. They were the presence. I mean, we were frantic, and yet having this social worker and having this chaplain, they were not only, every time they were on the unit, they not only were caring for these patients, they were caring for me. And I will always, always remember those two people. I mean, I remember them vividly. It's 47 years ago. I remember I remember them so vividly, the impact they had on me.
Wow.
And then, from that was my kind of clinical beginnings, but then much like the field of chaplaincy now, I started realizing that if you want to change practice, like chaplains want to change practice, right? People like you, Danielle, you're doing this work because you want to change practice. And I realized that to change practice, you needed data, right?
Okay.
And so I thought, I got to go back to school. I did not want to go back to school. I promised God I would not go back to school. Get me through my nursing program, and I swear I'll never do this again. But I realized I have to do it, right? So you can identify with this. You're back.
Absolutely.
Yeah, right.
Yeah.
So I thought I got to have data, and that was what led me to my master's program. In my master's program, I studied pain and control of pain, and then I went on. I realized I have to get the doctorate. Got to do it. And in my doctoral work, I really focused on grief and grief of family members, as the very first patients were dying at home in my area. And so this was a huge thing, a shocking thing, that a patient was going to actually die at home. And I wanted to know, what was this like for the family. But what I began to realize, and then as I started my first full-time job as a researcher, is that spirituality was really left out, that it was not a part of the care that most people were receiving, and it certainly was not a part of research. And so that was really my clinical beginnings and my research beginnings. And so it's wonderful, Danielle, that you're here, because you are a chaplain and you're seeking the same path of getting the research skills so you can tell the story about spiritual care.
Yeah, absolutely. My path was, much different, but it definitely involved the push of a nurse practitioner. I actually started out in sports chaplaincy. And over time, after getting a master's of divinity and then doing some CPE and clinical training, I ended up being a trauma chaplain. And after I was a trauma chaplain, I became a palliative care chaplain, and I switched hospitals. It was the first time where a physician, I walked into the room, and it was a pulmonary critical care physician. And I was like, oh, I'm so sorry, let me step out. And he moved aside and he said, no, I'm here to learn from you. And I thought, oh, okay. And it was the first time I had actually experienced working with interdisciplinary professionals, the nurse practitioners, working with, the social workers, in a way where I thought, oh, okay, this is really impactful. And what is documented? What are the evidence-based practices? How are we getting here? What are the things that are proven to work in order to provide quality whole person care? And so and I started working, transparently on an article with a nurse practitioner who said, what are you going to do with this information that you have? What are you going to do with your clinical experiences? And I was like, maybe I'll get a PhD. And she said, you absolutely should. And so from there, she really pushed me into, the PhD program that I'm in now at the University of Maryland, Baltimore. But it is a really fascinating, one of the things that I hear you speaking about, and that I also experience, is the spiritual care, not only for the patients and the families, but also for the staff. And the way that impacts. Can you talk a little bit about how that impacted you? And then I'm happy to share about the ways in which, it facilitates and makes my job easier, as well as working, because I am embedded in a palliative care team, and we often go in double. So I often will go with a physician or a nurse practitioner. But I would love to hear about kind of your experience with the staff. As you said, it was really deeply meaningful, but also going in pairs. I think a lot of times, depending on the program, people provide clinical practice in silos.
Sure, right. Yeah, one of the really interesting things, sparked by what you just said, is several years ago when we were doing some spiritual care work and some research, and I realize that most people do not understand what chaplains do, and they certainly don't understand what knowledge you have, your preparation. And we were at the time had the opportunity to access a lot of nurses and ask a lot of nurses, what do chaplains do? And when we were asking clinical nurses that question, what do you think chaplains do? The answer was, well, when we have a real crisis, when things are falling apart, call the chaplain. So that was the first aha, like, really, it would be a good idea to call them way earlier, right? But then when we said, well, what happens? What do the chaplains do? The nurses would kind of look at me like I was crazy, and they'd say, well, I don't know. We call them, they go to the room, they close the door, they leave. I mean, generally once they're gone and we go back in the room, things are better. They helped, right? But I have no idea what they did. And so I started saying to my chaplain colleagues, like, this is trouble, right? Because if people don't understand what you do or what you know, how can they possibly know when to call on you, right?
Right.
And so I've been so fortunate my whole career to have known amazing chaplains, to have learned from amazing chaplains, and to witness what they do. But I always say to nurses, especially new nurses and physicians, like, if ever you have the opportunity to go with a chaplain, watch the chaplain, it will change your practice, forever. And I have to sort of put in a little plug. My daughter is a pulmonary critical care physician, and several years ago, she was in her first year of medical school, her very first year of medical school. In the first 2 weeks of medical school, every medical student spent a day with the chaplain. And, I'm her mother. Why would she listen to me all these years, right? But, she came home from that and it was like the world had changed. And I'm confident that a day with the chaplain in that first few weeks of medical school has changed her whole career forever, right?
Wow.
Every patient she interacts with, how she practices as a physician is different because she saw it. She understands, right? She saw someone have a conversation about spirituality. She saw how, a chaplain is truly present. And so I think that's just a huge, huge beginning of the work that needs to be done, is that before we can do research together or before we can advance this field together, there's such a need for the clinical world to have a better understanding of chaplains and what is your training, and what do you do, and what can we learn from you? And it's, of course, our entire field of palliative care is about interdisciplinary care. Like, yes, it's when I'm with the social worker, a physician colleague, a chaplain, that the care is different, right? And collectively, we are so much more. And so, it's wonderful that we have you, Danielle, and your colleagues that get that, that are understanding none of us are to serve the patients in isolation. We are to partner, right?
Right. One of the things that I encounter quite a bit when we do go in pairs, when we go with physicians, is I feel that I can operate kind of at the top of my training and my licensure. And then the feedback I get from my colleagues is, it was really nice that we could do both. We could address the physical and the spiritual and the emotional. And it's almost like this beautiful choreography when you're in the room. And the feedback is that, the physician gets to operate as well on the top of their license, because not only are they addressing the physical pain, but the spiritual and the emotional is being addressed as well. And so it's nice. And I think the other aspect of it is there is a cultural component when you go with more than one person at a time, when you get to watch the way a nurse practitioner or a physician kind of addresses cultural or ethical aspect or ethnicity and those aspects of care. You get to learn from each other, I think, in a really, really large way. And so that's one of the things that I've completely appreciated about going in pairs and doubles. where it will say, I didn't really connect with this patient in the way that I thought that I would. And I think the relief of going in pairs is that if I know what my partner or the physician or the nurse practitioner is trying to get at, and it's not really coming from the patient, I get to try it from a different approach, from a different training. And both of us are better clinicians. Both of us provide better patient care because of
Right.
it.
Yeah, exactly. Wonderful. I have a very dear friend and colleague I've known my whole career, Judy Pace, very much a part of all of our LMIC work. And Judy, many, many years ago, I learned from her, Judy said as a nurse, advanced practice nurse, she does a full physical exam, history, usually seeing patients for the first time for a pain consult. And then after, examining their body and asking all these questions about their bowels and their doses of pain medicine, after all of that, she sort of takes a pause and there's a silence. And then she says to the patient, I have asked you a lot of questions about your physical pain. I've examined you. And then she'll place her hand over her heart and she'll say, and now I want to know from you about the pain here, the pain in your soul. And it's just such a beautiful way to think about what we do, that yes, you have a physical problem, cancer, heart failure, COPD, whatever it is. And yes, we want to know all about that. But now the fact that I walk in the room with the chaplain, right? Or with my social work colleague, that is a message that says, I understand that you are a whole person, right? You're not just a tumor, right? You're not just a bundle of nerves around a hurting spine. You are a human being, a whole person. And so that is why our care here includes chaplaincy and nursing and medicine and social work and a lot of other people. And, patients, like, I can't tell you how many times patients have said, my doctor asked me about spirituality. And, patients will say, I'm not really a religious person, but when the doctor asked me about spirituality, it was the first time I really felt like this hospital was seeing me as a human being, right? So the presence of chaplaincy, the every one of us as clinicians that ask about spirituality, it changes everything, right? It is, right? What are we doing? We are not just here, doing tests and handing out medications. We're here to care for you as a sacred human being.
Right. And that, it's the goal with the whole person care.
Right.
It's deeply moving. I think it not only impacts the patients, but I can say it impacts me too. It increases my job satisfaction, the meaning that I get from my work. And I think honestly, it is an antidote for burnout.
Right. I've often shared the first time, and this is many, many years ago, it was actually not even at my hospital. I was visiting another hospital, and it was around Nurses Week. And I was making rounds on some units, and as we walked on a unit, I happened to walk in just as the chaplains were doing a blessing of the hands at the nurses station. So it was the first time I'd seen it, and I was just, I was so moved. I mean, I think it was just like immobilized to see this thing happen. But what I will always remember is I sort of watched this, the chaplain blessing whoever walked through. Some of the, the nurses knew the chaplains were coming up. A lot of the doctors were just sort of racing through to make rounds or go, grab a chart. And they didn't know what they were walking into. They were like, what's going on? And, the chaplain would just say, it's a simple blessing of the hands. But what I remember is a few minutes later, I, was leaving that area, and I saw a physician walking down the hall just staring at his hands after having that blessing.
Oh.
And then a few minutes later, the elevator doors open, and there was a physician in the elevator from, another area where he had also been, having the blessings, just staring at his hands. And that made such an impression on me, because I thought, we busy, crazy clinicians don't pause to remember who we are, right? I'm not a robot. I'm not a mechanic. I'm a nurse, right? I'm a human being caring for a human being. And as much as what medicines I give or, tests I, perform or tubes I insert, I am here with you. I'm connected with you as another sacred person. And, when you see yourself as providing spiritual care, as when you see your work, as sacred work, it changes everything. And I'll just say for you as a chaplain and for any chaplain, I mean, even in the busy, chaotic craziness on any unit, clinic, at this moment as we speak, the moment a chaplain just walks onto the unit, it changes things, right? Because it is that moment of these are spiritual beings I'm caring for, right?
Right. That actually got me a little weepy. It was so beautiful. And it actually allowed me to really kind of reflect on a time where, I think it comes more from my trauma training, but there are moments where if, a physician is putting a line in and they can't get it in and the patient is, screaming, or if they're, a newer resident and they're trying to do a type of procedure, I often will go in and I will say to the patient, you're in good hands.
Yeah.
The person is here to care for
Wonderful.
you.
Yeah.
And it resets not only the patient, but also the doctor.
Yeah.
And so my goal is often to create that space and to remind everyone that this is sacred work.
Mm-hmm.
And that we're not just treating the physical, we're not just physical beings.
Mm-hmm.
There is a spiritual component to almost everything that we do.
Right.
And so I think, as you were sharing, it reminded me of those moments in my own practice when I'm doing chaplaincy in the ICUs.
Mm-hmm.
I do have a question from what we've been talking about. It's as someone who does, I mean, I know that you have well over 500 publications. And so someone who is well versed and who does interprofessional, interdisciplinary research, can you speak a little bit to how do we let our clinical practices as we work together kind of inform so that we're not just holding these moments, right? So we're not, but that we're also disseminating them to the world, that we're, influencing practice. How do we, can you speak to a little bit about how to keep that in mind in the research aspect?
Sure. I think we share a lot that, when I was starting out as a nurse and the people I worked with cared a lot about what's the next chemo drug and, can we begin to shrink tumors? And yet I was very acutely aware, like no one is thinking of the human being in that bed, right? This is a mother. This is, this man just told me his, wife is at home and she's sicker than he is. And his distress is about, abandoning her. So I think that I started feeling like I had to start telling the story, right? I mean, I had to, I never set out to write 500 papers, but I set out to write one, right? Like I got to write one paper. I have to publish a paper, or, the first time that you present at a medical meeting or interdisciplinary meeting, then you feel like you have to, the problem is you are invisible, right? Like the things I cared about, whole person care, people as human beings, relationships, that was not on the agenda, right? It was not part of the reality. And so until we started speaking of these things and submitting our abstracts to meetings and writing papers and publishing, and we had to make this visible, right? For it to be known and recognized. And that is a long, hard road And I could tell you horror stories of those many years of trying to do that. But, I think the world has changed, right? There are different people entering the workforce now. And, I'm amazed at the number of new physicians, nurses, social workers, psychologists, who I'm always ready to like take them on, like, make my case about spiritual care. And they're like, well, of course, spiritual care is important. Like, who wouldn't believe that, right? And so, but you have to do it, right? You have to do it. And so it's so, so, so important what's happening now to see many chaplains, whether, chaplains who are going to school or just, chaplains who are in the clinical area that are writing articles, writing case studies, presenting at meetings, being on panels, being part of academic activities, because, the story is compelling, right? And, I always say, like, for years and years writing, being a part of all these palliative care guidelines, people always say, what's the definition of palliative care? And I can quote the WHO definition or the national consensus definition, but I always say the best definition is, I'll tell you exactly what palliative care is. Palliative care is the kind of care you would want if you were sick or somebody you loved was seriously ill, right? And I think the exact same thing is true for spiritual care. Like, if you or someone you loved was seriously ill or dying, like, wouldn't you want, someone at the bedside to say, tell me who you are. Do you have regrets? Who do you love? How do you want to be remembered, right? Like, are you a religious person? Does your faith offer comfort? Like, isn't that what we would want? And so how can we not advocate that for the people that we care for? Because to not do that is unthinkable in my mind. Like, how can you care for very sick and dying people and ignore their spirituality? How can that even be a possibility?
I was thinking about, I'm reminded of actually in one of your papers, it says spiritual care assessments are just as important as pain and symptom management assessments. And it stood out to me even still. And so just trying to constantly, I think, change the culture, hospital culture, and I think ultimately some policy change.
Absolutely, right. I mean, we have to have the structures, right? I don't know of any clinical setting in the country, I don't know of, that has enough chaplains, right? And I try to always say that we can't just have chaplains advocating for chaplaincy, right? We need every clinician to advocate for chaplaincy, because first of all, if you want to support the clinical staff, you need more chaplains, right? You want to keep nurses, you want to support physicians in the midst of, pandemics and now the aftermath of pandemics, like, have chaplains. We need chaplains. We need to build in, what are we doing to assess spirituality? I mean, in most hospitals in America, even now in, 2024, we have this admission checklist. Who do you live with? Are you constipated? Are you religious? Like, what kind of spiritual assessment is that, right? Like, right. And so we have to teach. So we need to teach the resident. We need to teach the medical student, the new social work student, the new nurse, that as a part of their assessing who is this person before you, we have to ask, do you consider yourself a spiritual person? Are you part of a faith community? Does your faith offer you support at this time? Or, Harvey Chachanov's work, ask the patient at the end of your usual physical, what should I know about you to provide care for you? When you ask those questions, people will tell you about their spirituality. If we don't ask the questions, you will never get the answer, right? Right. When we ask, I mean, you, Danielle, could tell us 1,000 stories about what happens when you ask the question, right?
It's true. It's true. I mean, even I asked a patient recently, I said, I said, what do you want me to know about you? And, it's this, well, my faith is really important to me. And it unfolded a huge opening in the way that he made medical decisions. It was based around his religion and his spirituality. And so being able to include, his faith leaders as appropriate and that was important to him. And it had resulted in advanced care planning. And it was it was just a huge benefit to being able to progress his care. And if I hadn't asked, I don't know that it would have been.
Right.
If there wasn't a spiritual care component, I don't know that it would have actually unfolded into the information that the medical providers needed, really.
Right.
And so the way that these questions of spiritual care really intertwine and they are a part of healthcare is genuinely and deeply important.
We did a study of many years ago, but it was one of our first times to really explore spirituality and family caregivers, which I just loved because, often we're so busy thinking about the patient, but what about the family caregiver? If you assess the needs of the caregiver. And when we interviewed family caregivers and we said, tell us about your spirituality, they talked about relationships, right? But then as they would talk, they would talk about, I'm the caregiver for my wife. Well, tell me more about that. Well, I want to be a good husband, right?
Right.
What does that mean to you? And then you would get to the story of the deep faith, that the faith of my grandparents, right? I always often say to nurses, you really want to know about somebody, ask them about their grandparents, right? Because if you ask about your grandparents, then you're going to hear the lessons you learned. And the memory and who am I? And I am who I am because of, where I came from. And so, these things that we think are not so related are deeply related, right? Of who you are and who is your family and what should I know about you? Those are open doors to who are you as a spiritual being.
I think a beautiful thing about the questioning through the family is particularly the grandparents, which I love, is that it also, I think, builds a bridge for culture and ethnicity as well, and understanding that influence within the patient and their family and the caregivers, as well as within their spirituality. And so,
I think on the topic of diversity, I keep saying to all chaplains, like, you are missing the opportunity. Like, every hospital in America, every clinical place in America has a DEI program now, right? Long overdue, very important. How can you possibly talk about diversity and cultural respect without talking about spirituality, right? Like, that's impossible. And so, all of our hospitals have been quick to say, oh, yes, we need to do better with diversity. The question is, what are you doing about religious diversity? What are you doing about respect for spirituality? Because it's much like, here in my hospital many years ago, I was a part of a sort of an ethics group and a conversation about, we have all of these patients in the ICU where there were conflicts between what the family thought should be happening, what the clinicians thought, was happening. And so there were, a number of people that said, oh, it's these Hispanic patients, this is the Hispanic community. We need to, learn more about Hispanic culture. But when you really went to, to talk to these families, what you learned is that it wasn't about being Hispanic, it was about being Catholic, right?
Right.
So again, we missed it. And so we have to understand that a very, very, very big part of this element of diversity, which we should all embrace, right? To embrace diversity and a commitment to diversity is to embrace a commitment to whole people. But we have to also be very strong spokespeople, is to say, you will never, ever improve DEI if you're ignoring spirituality. It should be the center of what we do.
That is deeply, deeply important to me for a number of reasons and personally. One of the things I think about often, and in transparency, the hospital that I serve is predominantly Black and Brown, is that racial concordance in healthcare really matters. And I also think exactly what you're saying is that if there is some type of understanding of who people are and their spirituality, that builds a bridge. I also recognize that if there is spiritual or religious concordance, that probably matters. And so, you know, I think about how do we, I agree that you cannot address the DEI, the diversity, the equity, and the inclusion without including spirituality and religion, as they're so deeply embedded into culture and who people are and what makes them up as a whole being. And so, yeah, I think about that often. And I know in the recent paper that was published, Spirituality in Patients with Cancer, I think one of the deficits in research that you noted was about kind of what is the cultural and ethnic impact on spirituality, and how can we kind of navigate that in the research field, but also, you know, in the hospitals. And so I think it's a great point. I often, after family meetings, will stay behind.
Yes.
And the families will say, okay, chaplain, but what's really happening?
Right. It's about trust, right? Yes, of course. And you're interpreting, like all the language, like all of that is now somebody needs to stay behind and say, let me interpret for you, right?
And even if there isn't the spiritual concordance or racial concordance, it's, you have asked about this aspect of me. And so you have the trust, and I want you to tell me what's really happening.
Yes, right.
And
absolutely.
it builds, and it has, you know, it's that bridge. I think that's just it's a beautiful connection point. I think that we have an opportunity at least to improve on connecting in those ways.
Right. Absolutely. Who should think of having a family conference without a chaplain? Like, that doesn't make sense, right? So,
and I think you do bring up a wonderful point that it's not always race or ethnicity. A lot of times it is really just about the religious or the spiritual aspect of care, and trying to navigate that. And to your point that, you know, including the chaplain as well, being a generalist, it's all really, really important. And matters within the patient care. So it's really, I appreciate that. I have a question. So when we were talking a little bit earlier about kind of the policies and the questions that we currently have within the intake, and how, you know, it would all produce more data. I think I was thinking a lot about that. And if some of those questions were embedded a little bit more in a systemic way and enforced through policy. And, you know, I guess I would ask kind of what, for the people who are in spiritual care research, what is something that you're kind of looking to in the future, that you're looking to see? If we at least hope, if we can partially get some of that data and start gathering.
You know, I think we're really just beginning to have good spiritual care research, and one of the big reasons is because we haven't had spiritual care providers doing the research, right? I mean, people like me, you know, I'm a nurse, and for now, you know, 30 years I've learned to include, or 35 years I've learned to include spirituality in my research. But I think until we really have the expertise of chaplains and other spiritual care leaders, that, you know, we're not there. And so it's really, really important. It's important for chaplains to be a part of research teams, right? And it's important for chaplains to become researchers themselves, to generate a body of knowledge. And it's, you know, it's very much like when I started as a nurse 47, almost 48 years ago, you know, it was the world of medicine only. There wasn't a voice of nursing. And so when nurses started asking questions like, well, what about the children? And, you know, what about the caregiver? And, you know, what psychologically what's happening with this woman who just lost her breasts, right? Like, we know how to do, you know, a mastectomy now, but what does that mean to this woman? Like, until we were there to ask the question, then there was this void. And I think we're at the very beginnings in spiritual care, that we need to tell the stories, you know, qualitative, like, please remember, research is not just quantitative. In my mind, the best research, the most important research, the paradigm changing research has been qualitative. And so we need good qualitative work that captures the meaning, you know, the essence of these human experiences in illness. And so I'll give you one little example. Many, many years ago, I was doing one of the first of our pain studies about children in pain. And we were trying to get at why are these children in pain? You know, why are they not getting their pain medicine, right? A very biomedical, you know, kind of question. But when we went to interview parents of children with pain, actually very quickly I realized these were children with cancer. And at that point in time, most of these children had very poor prognosis. So it was really about dying children, but nobody was even acknowledging that, right?
Oh, wow.
But the very first parent, you know, we interviewed, went into the room, and you know, the father said, oh, you know, we said, how are you doing? You know, what's going on? This must be really hard. And he said, yeah, it's really hard. You know, we have a younger child at home. My wife, I come and stay all night. In the morning, my wife relieves me. You know, I go home, take care of our son, go to work, whatever. But as we're trying to ask this question, you know, tell me about pain, what it's like to have a child with cancer and a child with pain. What, you know, the father said, well, you know, I got here this morning in the early hours and you know, went in to see my daughter, and my daughter said there were angels in the room. And I was thinking, wow, wow, this is it. Like, this is what I wanted to learn about, right? This is it. So I said, tell me more, you know. And so he says, oh, so I'm thinking, oh, how incredible that this father had this experience, and now his daughter can tell him, you know, the angels were here with me. And so, but we said to the father, and what did you say? And the father said, I told her, there are no angels in this room. You are here with me, right now. Devastating. I mean, we were devastated.
Yeah.
But what was the dynamic? The dynamic was no one was talking to this father about his daughter was going to die. And
Right.
certainly no one was asking about spirituality. And nobody was in that room talking to this little girl, you know, about her experience, right? And worse than that, you know, when confronted, you know, when the daughter tries to tell her father, what does he say? There are no angels here. You're with me, right? The total absence of support for this family
Yeah.
to squash, you know, this spiritual experience. Well, guess what? We went to the second parent and asked the same questions. This was not a spirituality study. It was a pain study. But we went to the second parent, and guess what that parent told us? My son said that an angel came here last night and they brought a ladder and that he's going to heaven. And when we said, and what did you say? The parents said, you're not going anywhere. You're here with me, right?
Wow.
So, like, again, I'm here to study pain, but I'm the researcher. I have my agenda. My agenda is learning about pain. But what is the agenda of real people? What is the agenda of patients and families? This is, our patients are having spiritual experiences. We are the ones ignoring it, right? And so that's why we do this work, right? That's why you're a chaplain, right? Because
Right.
you're the witness to the story. You're the presence in that room, you know, in the new patient, you know, team meeting or in the family conversation. You are the person that says, let's pause for a minute and let me ask, how is your faith? sustaining you through this time, right?
Right.
And then as researchers, this is what we do, right? As researchers, we gather data, whether it be quantitative or qualitative data, but we gather data so that we can tell the story. That's what research is about, right? And to go back from where we started, I see Paul's back in the room. He's going to make us quit talking. But that's why we do this work, is to tell the story, because we can't change care if the stories are hidden and unspoken.
Beautiful.
Paul,
Yeah, I'm clutching my heart too. I'm doing I'm doing a little run on AFib here as well. Get me some, amiodarone or something here. This was great. Thank you, Betty and Danielle. There's a couple of questions that had come in. I think because of the nourishing conversation that you've had along this way here, I don't want to cut things off too much. I know, following the program or format, I'm happy to jump in, but are there any last words, Betty or Danielle, between one another that you'd want to?
Thank you. I think her, talking about the story and the fact that research is to capture that and to share that. I don't know if I can, that I think is probably, it's just deeply memorable and meaningful. So I will leave it with that. And thank you so much.
thanks. It's so nice to be with you. And I'm so grateful for you and your colleagues that are trying to change the daily care of patients and families, but also to change what we know, to do research, to speak, right, to do all of this. We're also very grateful. Paul, do we have time for any questions? Where there's a question
Yes.
in the chat
Yeah,
to ask? Answer.
Yeah, early on, a quick question came in about where your daughter went to med school and that program that they did with medical student shadowing of chaplains. I know there's other places that do that, but curious was where specifically she did med school.
She was at UCLA, and actually in the first month she went with the chaplain for a day. And the other thing she did was she was assigned to go to a home visit. And the home visit in her case was a young adolescent or a young child who had a near drowning and now was, really very, very incapacitated, being cared for, required total care by parents 24 hours a day. And I always think those two experiences changed everything, because, as young medical students, you think the world is the hospital, right? That this is healthcare. No, healthcare is in people's living rooms, right? And so she got to see both what illness really means when you're caring for a very disabled child 24 hours a day, 7 days a week in your living room. And she got to see what spiritual care looks like. And so that changes everything, and is why she's such a wonderful doctor today.
There's no bias.
No bias. Best. Yeah.
Well, speaking of research, speaking of bias, a question came in. If there's time, I definitely have a question for you, Betty. But the question was, would you please unpack? This was just going back to when you and Danielle were wrapping up your conversation. Will you please unpack a bit further what you mean by quote qualitative end quote research that is needed and your vision for spiritual care research, and then additionally, how best to capture these data?
Mm-hmm. So in terms of just the quantitative and qualitative, I think it's really important that we're using quantitative measures. So in all of my studies for all of these years, we've used the FACET tool lots of times, and then we have a quality of life tool that has the spiritual domain. And so, and Paul, I don't have those two citations, but we actually just did a synthesis of 30 years of spiritual care research and published one paper on 30 years worth of family caregiver spirituality, and another paper on 30 years worth of patient spirituality. And the family caregiver paper just came out in Journal of Palliative Medicine, and the patient paper just came out in Psycho-Oncology. So both Paul and I are on there. You could search our names there. But what those papers show is that, yes, we need the quantitative tools, because when we have numbers, right, we have data. And so then we can do correlations of how is spiritual distress related to overall psychological distress? Or how is spirituality related to quality of life? So we need the quantitative, but we also need the qualitative, because, spirituality is very much a lived human experience. So interviews that we've done, tape recorded interviews, open-ended questions. We've done a lot of spirituality research with professionals as well, interviewing, nurses, physicians, and others. And so I just, as we all know, a lot of things can't be quantified, and the what you learn from an interview or even a focus group or interviews of caregivers is really the important stuff. So that's what I meant by doing both the quantitative and the qualitative. And then Danielle, you're in this doctor program. Did you want to comment on spirituality research or methods?
I very much appreciate a lot of the qualitative. I think, as a lot of chaplains, getting the narrative and listening to the narrative is a big piece, and it comes a little bit more intuitive to me and to my history as a chaplain. But I do also want to echo that the quantitative portion is also really, really important. And so I think the numbers and the measurements that we take are also, I'm trying to constantly be mindful of doing mixed methods and including both.
Right. Yeah.
And not just, the thing that I kind of draw to, which is getting the story and capturing the story and looking at the themes, but also, how many patients, what types of races, ethnicities, what do the demographics look like, what's happening, just to be able to broaden the areas of research. And the effectiveness and the impact to it, I think is important as well.
Right.
Great stuff. I'm going to keep us moving. I'm going to get to this next question, and then friends, we'll see if we get to the other questions in the chat. I so appreciate the liveliness of it. So the next question is, I'm a hospice chaplain. Most of our hospice staff are very open to chaplain participation in care, but some care managers seem to be threatened by chaplain and are resistant to a chaplain accompanying them. Do you have any suggestions for helping encourage them to accept chaplaincy care for that partnership?
I think it's a slow process, right? And we learn, we will convince people by our actions and by what they see, more than just trying to change the rules, right? And we know there's a lot of factors, right? Things are so crazy in every clinical setting right now. People are so stressed and overwhelmed. And so, that case manager who's saying, no, I'm not going to take a chaplain with me, is probably saying, I don't have time. And if having you in the room makes this take 5 more minutes, like, it's over, right? So I think that, it's kind of like when the field of palliative care started, people were glad to let you come see the patient who was dying in the next 24 hours, but not so ready for you to see the patient that was newly diagnosed. But it took just, okay, you want me to just see the dying people, I'll see the dying people, right? And I think we get in there and we do what we can do, and we keep teaching, and we know that change takes time. And maybe it's not every patient that, you go do a joint visit. But people will see what you do. They have to learn what you do. And I do think that's still a problem. Like, why would I want a chaplain to come with me to do this case management visit? Like, why do I need a chaplain, right? Well, because maybe you really don't know the answer to that question. And so the more as a clinician that you learn what the chaplain can do, like, you're the case manager and you're ripping your hair out because this patient lives alone and they're going home, and you don't know how in the heck is this going to work out. They live in a 3-story apartment, no elevator, and no one to take care of them, and how are they going to get medications? That's what you're thinking as a case manager. But the chaplain could come in and say, what about your faith community, and how might that help, right? And so I think people first need to learn, how will you help them, right? How can you make that case manager's job a little easier? And then once they know what you can provide, then they're more willing to say, yes, come along. But I think we do have to just be tolerant because we live and work in such crazy places and times right now.
I will add, because I completely agree with really assessing if it's really about a resistance to the spiritual care itself, or if it's a time thing or a practice thing. I think the other thing is, to be honest, is that religion and spirituality is a really packed word, and it carries a lot of history for a lot of people. And particularly in clinical type settings. And so if the opportunity arises, or if it's appropriate, kind of, appropriately probing, is there reasons why you're resistant? Could we talk about that? These are the ways I find that it might be beneficial for the patient, and as Dr. Ferrell mentioned, how it could be beneficial to your practice as well, in terms of providing care and caring for the patient. I think being honest about that spiritual care it comes with a lot of baggage for a lot of people. And a lot of people, again, I'm echoing, but they don't necessarily always know what it means.
Okay, Betty, Danielle, friends, I apologize to those who submitted questions or anything in the chat. I like to stay on time. I want to be respectful of your time as well as the people who've been so kind. So to you, Betty, and you, Danielle, for the gifts of your expertise, for your time, for your passion for this work, so much gratitude. And thanks to all of you who chose to join us here to be a part of this interactive engagement with us today. This time of year, I wish you blessings for health and well-being, no matter how you celebrate these days, and blessings to all of you on your new year. Thanks for being a part of Transforming Chaplaincy. Take care, all.
Bye, everyone.